Hello everyone. Now I'll discuss question of neurology. Well, we have a 73-year-old man who is a known case of small cell lung cancer, and he has been brought to his general practitioner by his daughter since she's concerned the father has grown considerably weaker and she feels he may not be able to cope alone at home. On further questioning, the patient does report a problem with the walking upstairs or bending his legs to dress in the morning, and that he has got progressively worse over the last few months. He also reports problem with the dry mouth and swallowing as the food gets stuck in the throat. On examination, patient is mildly cachectic. On CNS examination, confirmed weakness of the muscle of the thigh and the hips. As far as, if we summarize, we are getting a 73-year-old male patient, known case of small cell lung cancer and primarily weakness in the lower limb, and he has some feature of dry mouth and swallowing also. Okay. Well, which of the following observation would best to diagnose this as a case of Lambert-Eaton syndrome? Well, lovely question. He has given you diagnosis also. But thing is, what he wants, that which of the following is really going to help you in making the best that this is suffering from Lambert-Eaton syndrome. Okay, what we also write as Lambert-Eaton myasthenic syndrome also is written sometime. Well, option A is correct. Involvement of the autonomic nervous system. Well, Lambert-Eaton syndrome, LEMS, usually occurs in association with malignancy. 50 to 70% of the LEMS case have identified malignancy, and the majority being small cell lung cancer. Okay. In fact, for all practical purposes, whenever you are getting LEMS in the exam, it is 99.9% they will be talking about small cell lung cancer. It's such an important point. Well, now what happened? This is due to autoimmune attack directed against the voltage-gated calcium channel, what we write as VGCC. So they have an antibody against the VGCC receptor in the presynaptic motor nerve terminal. Point to be noted, we have a term called myasthenia gravis. There we have antibody against the postsynaptic terminal. Here we are getting antibody against the presynaptic terminals. Well, how these patients present to us? Slowly progressive proximal muscle weakness. Point to note, in our case also, the gentleman presented with proximal muscle weakness. He had difficulty in bending the legs while wearing the pant, and he had difficulty in walking upstairs. Okay. Deep tendon reflexes are typically depressed or absent. This is a very important point to be noted. And that their recovery follows vigorous brief muscle activation is a pathognomic feature. And this we see when we do electrophysiological also, when we do repeated stimulation, and that lead to incremental response. On repeated stimulating a muscle, this is what we get in when we do electrophysiological studies. Incremental response. Why it is so important? Because in myasthenia gravis, if you repeatedly stimulate the muscle, we get decremental response. It's such an important point in myasthenia gravis. Okay. Well, now autonomic dysfunction is present in this patient, which can be dry mouth. From reduced elevation, the most classical finding, and that is there in our patient also in the question. Erectile dysfunction can occur in men, 45% cases. And these are not the feature in myasthenia gravis. An important point to differentiate from myasthenia gravis. In myasthenia gravis, autonomic nervous system is usually not involved. Now, which antibody are seen in LES? I already mentioned to you. We are getting voltage-gated calcium channel antibodies and these are the antibody against the presynaptic PQ type calcium channel in neuromuscular junction, to be more precise. Now let's look into other options. Can it be hyperreflexia? I only told you classically that may be normal or depressed, but their hyperreflexia is definitely not a feature. And remember, hyperreflexia again is the one point which is not there in myasthenia gravis also. This is a very important point to be noted. What about marked response to endophomium? Endophomium is very famous. The brand name is Tensilon. It's a acetylcholine inhibitor and has a rapid duration, rapid action, rapid onset of action, and short duration. So it prolongs the presence of acetylcholine in the neuromuscular junction and result in immediate increase in muscle strength. It's used to be one of the diagnostic tests for myasthenia gravis. It used to use as a screening test. But now it is not used much, okay, because there's a risk of arrhythmia and bronchospasm, and definitely this is not helpful at all in case of LEMS. Facilitation shown on testing of several muscle groups. Brief maximal isometric contraction of the relevant muscle can sometimes lead to temporary appearance of previously depressed or absent reflexes. I discuss in these cases reflexes are diminished, but if we keep on repeated stimulation, which I also mentioned that we tend to get incremental response, that means the muscle have better contraction after repeated stimulation. Similarly, when we repeatedly stimulate, the reflexes may become normal or it may become hyperreflexive also. And this can be seen in electrophysiologically by our nerve connection studies. The interpretation is quite subjective, therefore not a good answer at the presence of autonomic dysfunction. Okay. Now what is facilitation? I talked to you regarding facilitation, but what is it? Stop the video, write down the answer. Enhancement of response to a neuron to a stimulus following prior stimulation. Other way is incremental response. Like this, repeated stimulation lead to enhancement of response. Incremental response is the other way name for facilitation. Now let's look into other options. Respiratory and oropharyngeal muscle, they are usually not involved. They may be involved in case of myasthenia gravis, but they are usually not involved in LEMS. Now let me give you a lovely chart, golden line to remember, difference between myasthenia gravis and Lambert-Eaton syndrome. It is most common neuromuscular junction is myasthenia gravis, is uncommon. Antibody to post-synaptic acetylcholine receptor. Here autoantibody to presynaptic calcium channel, the acetylcholine level is release is decreased. Ptosis, diplopia, weakness, worse in the evening, and it will become worse on muscle use. Proximal muscle weakness, autonomic dysfunction, and the weakness improve on use. Here the weakness reduces on use. Thymoma may be associated, and here small cell lung cancer, very, very important line. I think this is one of the most important line that you got to remember. And what about if you give reverse symptom endophomium to diagnose and pyridostigmine to treat? And here we don't have much effect with this. So this is a summary, lovely summary to differentiate between the two. Okay. So I can go out of this field so that, yeah, you can see it better now. Thank you very much.